So thank you, Dr. Radania. Now, our next speaker is Dr. Bender Al-Aqil. He's going to be speaking to us about how to prevent and manage caregiver stress and prevention and assessment of caregiver burden. Dr. Al-Aqil is a consultant geriatric psychiatrist at King Abdulaziz Medical City. Thank you, Dr. Bender.
Assalamu alaikum. Thanks for the conference organizers for accommodating me. My talk initially was yesterday, but due to unforeseen circumstances, it was moved to today. So, as you know, we are really busy in the clinics, and we don't have time to discuss too many issues. We typically focus on the patients, but we have a lot of things to focus on. So quite often we forget to talk with the caregivers about their suffering, their journey with Alzheimer's disease or other dementias, and how they are doing with that. So today I'm going to focus on that. Unfortunately, when I was preparing for this topic, there are not too many research was done on the area. It has been kind of neglected. I was looking for more kind of, psychological plus pharmacological interventions. The evidence for pharmacological interventions was kind of scarce. Mostly it was psychological interventions. I'm just waiting for my slides. I think. Okay, so what I'm going to talk about is assessment of caregiver stress, research in the area of managing caregiver stress, and common psychotherapies that are used to manage caregiver stress. And the objectives for my talk is being familiar with ways to assess dementia caregiver stress, being more comfortable in initiating possibly uncomfortable discussions with caregivers, and understand clinical research findings in the area of managing caregiver stress, and being familiar with the most used forms of psychotherapies and understanding their principles. I think the most difficult step typically is like how to start conversation with your patients and their caregivers. So in the course of follow-up visit, simply asking the question of the caregiver, how are you doing? And listening to the response may be the single most important part of the visit. Although we often cannot solve the problems they are facing, letting them know we are aware and concerned can do a world of good. Quite often, the caregivers will be surprised. When I ask them, how are you doing? They said, who, me? I said, yes, you. Because typically they come to the clinic or the hospital feeling, okay, the focus is going to be on the patient himself or herself. They will not expect the healthcare practitioner to focus on them. So shifting the focus and just kind of asking them, how are you doing? And just listening from them could do a lot of kind of comfort to them. And but as you know, we're really busy in the clinic. We have limited time. So just kind of, focusing on few things, for example, are you sleeping at night? Could be really an important part because, as you know, dementia patients, they will have disturbed sleep cycle. So asking these simple questions could be very useful. So how to initiate or catalyze the discussion? So for example, here just included some kind of questions that you could use in your clinic to catalyze the process of discussing with the caregiver. So for example here, to provide the very best patient care, I find I need to also pay attention to my patient's caregivers. Can you tell me a bit about how are you feeling or doing? We know that caregivers often neglect their own health. When was the last time that you saw your physician? That is very common. I ask patients and they say, well, I didn't go to do my checkup. I have high blood pressure that I haven't been taking the medications for. My diabetes and blood sugar is all over the place. So they are neglecting their health because they are so busy focusing on the patient. Another question focusing on quality of life. I know that many family caregivers find the role to be very stressful. How are you coping with these responsibilities? How would you describe your quality of life these days? How often do you get out? What do you do for fun? Quite often I get the answer what do you do for fun? Zero, nothing. Just focusing on my mom who has dementia. Quite often I spend the time just, convincing them, please go out. Please have somebody else come from your family. I know they will not be as good as you in terms of managing your mom's medications, but it's really important for your mom's health to be also healthy yourself. So please go out, have fun, go with friends. Even like 2 hours, 3 hours a week could be enough. The problem quite often is, as you know, the caregiver will, or the caregiving will lie on one person in the family quite often. Typically is the daughter who is not married, and who is going to be taking care of her mom or her dad. And the problem is that this person could have also what we call obsessive personalities, like they have perfectionist tendencies. They will not allow the other family members to kind of come in and help out because what they are doing is not good enough. So quite often they will get the burden, they will be depressed. Eventually, they will collapse. So quite often doing a preventative role initially could be very useful. So again, with some of the questions, many caregivers do not want to burden. Are there times when you really need help but don't ask for fear of being a burden, which is quite often. The problem is when the caregiver enters the phase of depression, they will have the symptoms of depression, hopelessness, helplessness, but also they will feel also there's reduced kind of self-confidence, and then they will not have the confidence to ask for help when they're depressed. So they get into the cycle of depression and more depression because they're not asking for help. Who gives you support? How helpful is the support? We work with a psychologist who is an expert in assisting caregivers. May I refer you to this individual? At the National Guard Hospital in Riyadh, we are really pleased that we have Munira Al-Hadloul, who's going to present today at the end of the day in a workshop. She's a psychologist working with caregivers. Quite often what I do when I see the patient needs help in terms of cognitive behavioral therapy or other form of psychotherapies, or even just kind of assessment, I refer these patients or the caregivers to Munira. Caregiving is a very hard job, and the best way to do it well is to take advantage of some of the resources available for help. Are you using any of these resources? So kind of open the discussion to utilize the available resources to these caregivers. So in case of emergency, like if something happens to you as a caregiver, did you kind of organize a plan to take a place? So in terms of providing education and information, caregivers should be educated about the care recipient's illness and specific care needs. Quite often we don't have time to spend too much time in terms of education. So referring them to the Alzheimer's Society courses and website as well could be very helpful. Counseling about caregiver stress and its consequences and ameliorative strategies will help the caregiver to better cope. And caregivers may obtain relief by learning how to ask for help, engaging other family members to help, participating in support groups if it's available, and ensuring preservation of their own health. So technology could be useful, like for example, lift systems or monitors like GPS monitors for the patient could be helpful, reducing the burden to the family members. And also caregivers may need to be aware of assistance available to them or know that they qualify for help. So for example, some assistive services can be obtained by self-referral to the Saudi Alzheimer's Society that include assistance with non-medical home care services, housekeeping, for example, companionship, home health care services, for example, lab tests and meal delivery services, legal, financial, individual, and family counseling is also available. So quite often, families, they wouldn't know about these available resources. For example, the home health care is available in many hospitals. They're not aware that there's like home care services available for them. So let's talk a little bit about research that was done in the area. Unfortunately, not too many research that was done or studies, but one of the big studies that was done was the REACH study. In REACH study, basically, it's a large study in the States and multi-site. They did 2 scales. One is the Revised Memory and Behavior Problem Checklist and the 20-item Center for Epidemiological Studies depression scale. So they focus on the depression in the caregiver, and also they use the behavioral checklist for patients. And then caregivers were asked the baseline in 6 months. So multiple interventions were implemented, including skills training conditions, environmental skills building program, etc. So it was a huge study. The sample size was large. Unfortunately, it wasn't. The findings were a little bit disappointed. With all of these interventions, it was statistically not significant for the behavioral burden scale. It wasn't significant for the depression scale, but it was small, statistically significant, but small with the behavioral scale. So it was considered for the reviewers to be kind of almost a negative study. But the thing is that what they concluded in this study is that, you know, these interventions could be successful in achieving clinically meaningful outcomes, but their findings suggest combined interventions had an effect for those caregivers in most need of support. So what they suggest is to focusing interventions on the patients and caregivers, and being kind of more focused in interventions rather than providing a whole package that many patients might not need. So to be kind of selective. So for example, if the caregiver is depressed, provide more kind of evidence-based therapy, like cognitive behavioral therapy, rather than doing the whole package. So what they suggested that future research is necessary to test a multi-component intervention approach tailored to match specific characteristics of caregivers and their needs in order to maximize benefit. In this study is that they provide the package for all patients and caregivers. And this is why they suggested that it wasn't kind of a positive study. So they suggested more kind of screening to the needs of the patients and their caregivers. One multi-site study, which was most similar to REACH in terms of overall design, reported similar small reductions in caregivers' burden following case management intervention, and comparable to REACH findings. So the best evidence that we have lately in the last 20 years was based on psychological interventions. Again, you know, I couldn't find any good studies in terms of medications for patients with caregivers. I guess the approach is that you do your assessment. If you find the caregiver having significant clinical depression symptoms, then you can treat based on the guidelines, like, for example, medications plus or minus psychotherapy. But the best evidence they found in the last 20 years is for CBT, for the cognitive behavioral therapy. As you know, cognitive behavioral therapy has many indications, almost for everything now. It's like for addiction, for even medical problems like chronic pain, for anxiety, for depression, even for psychosis. Imagine that, like, you know, patients with schizophrenia now could be treated with cognitive behavioral therapy in addition to medication. But with every condition, there is like discussion in terms of which is best. Like, should I choose only CBT? Should I just choose medication alone? In general, most evidence would tell us like the combination is the most effective. For example, we have meta-analysis for suggesting if you combine cognitive behavioral therapy plus medications for depression, if you do the same thing for anxiety, you get better response and more rate of remission. So just gonna skip that. And CBT could be done online, could be done, like, for example, we have some apps now, for example, Lebbe, Senar, that could be used like over the phone. The patient could initiate the psychotherapy himself or herself over kind of video calls. Okay, so I'm just gonna skip that for. Okay, so we have something we call problem-solving therapy that has been also found to have evidence for caregiver stress. It's very simple, it's easy, you can do it at your office, even if you're not trained to do psychotherapy. So just kind of, you know, advising your caregiver that, you know, define your problem, develop multiple solutions, assess your solutions by writing advantages and disadvantages, and implement your solution. And then review what worked and what did not work. So you could suggest that to your caregiver when they present with a problem. Say, okay, maybe you can define the problem, write the solutions, advantage, disadvantage for each solution, and then choose what kind of best work for you. And maybe come next time, when I see you next time, let's have a discussion about that. So it doesn't have to be like to be fully trained in psychotherapy to do these kind of short interventions, and has a good evidence almost similar to doing the full package of CBT for patients with depression. So cognitive behavioral therapy, probably you have seen this kind of slide or cartoon before. So when we talk about CBT, cognitive behavioral therapy, we talk about thoughts in this kind of cognitive triangle, and then the feelings down, and then the behavior. So it's like, as you can see, the thoughts will lead to change in feelings, and then will lead to change in behavior. This is kind of the concept of cognitive behavioral therapy. So for example, when we explain to patients what kind of cognitive behavioral therapy is, we ask them to remember the last time that they felt depressed or anxious more than usual. And we bring the situation and we say, okay, what kind of thoughts went in your mind during that time? And what kind of feelings went in your mind at that time? And what kind of behavior did you do? For example, depression will lead to feeling of kind of negative feelings about the self-deprecation thoughts that will lead to feelings of being depressed further, and then lead to behavior of kind of withdrawal. They will not go out with friends, or they will not participate in the usual activities. So we analyze that in cognitive behavioral therapy. So the principles of cognitive behavioral therapy is maladaptive thoughts promote the continuous or continuation of psychological distress and behavioral difficulties. And CBT is a time-limited, present-oriented psychotherapy to help people modify dysfunctional thinking and behavior. But you have to select your patients. CBT doesn't work for everybody, and which is the most difficult challenge that I have in the clinic, is that patients would come, they would refer them to CBT, but they will not continue. They will come for 2 or 3 sessions, and that's it. Can you guess a number? Like, what would be the typical CBT number of sessions that the patient would require for, let's say, depression or anxiety? Any guess? Just kind of shout a number. That's right, 12. So 12 is the minimum. Like, you wouldn't find any study that talk about, like, 3 or 4 sessions. Unfortunately, when patients they have their insurance, the insurance will not cover for a long kind of course of CBT. They will cover for 3, and then they will have to ask for reapproval. And many patients, when ask them, like, did you try CBT? They say, yes, I tried it. Okay, how many times did you go to the therapist? Oh, 2 times, 3 times, 4 times. That doesn't work. I educate them. No study was done like 4 times cure for depression. You have to have at least 12 to 16 sessions. Some disorders, they will need even more. So we say the minimum is 12 sessions. So if the patient just went 2 times, just re-educate them. CBT needs time, needs work from you as well. Like, you didn't go there and listen to the therapist to tell you what to do. No, you go there. It's a project between you and the therapist. You will work together with the therapist. You will come up with goals, and then you will work on the goals. The first 4 sessions are usually the initial phase, so you wouldn't have an improvement. Actually, you might get worse. And I educate patients about that. You might get worse initially when you do psychotherapy, because you're opening a wound of, kind of worms, and that will bring a lot of kind of issues. The session from 4 to 8 is typically what we call the middle phase, and then session 8 to 12 is the terminal phase, where we kind of conclude the therapy. And also we tell patients, like, even if you get really improvement with CBT, please redo the CBT. Like, we have something we call boost sessions. Patients typically will go every 3 months to their therapist to have boost sessions to review what kind of has been done in the last 3 months and kind of redo some kind of the homework. Relaxation could be a useful thing as well if you have time to discuss that with your Okay, so I'll conclude that, and thank you very much for your attention.